Dr. Deeksha Kapoor, who's a consultant GI surgeon at BLK Max New Delhi, and she'll be discussing an overview of the management of carcinoma stomach. Because yesterday we have covered some topics, today we have covered, but everything cannot be covered. So that's the aim. So we have given her a task of giving you an overview of the management overall, what has not been covered essentially in these individual talks. So Dr. Diksha Kapoor.
Thank you, sir. Good evening, everyone. A big thank you to the organizers for involving me in this program. I hope I am able to do justice to the time and the topic that has been allotted to me. So I'm just going to bring things into perspective for a moment here. Between yesterday and today, we've already discussed the anatomy of the stomach, the lymph nodal stations and the drainage, the diagnosis and the staging modalities, use of minimally invasive techniques, robotic and laparoscopy in surgery, and the status of lymphadenectomy, the discussion just by Professor Sadaf right now. So I'm going to fill in the blanks, things which have not been discussed so far, and I'm going to focus on these three. The role of neoadjuvant therapy and adjuvant therapy, and how we factor in surgery, and how do we place and create our equation to give the patient the best possible survival outcome. This is the SEER database graph from 1973 to 2005. This included data of some 11,000 patients. And I want to bring into perspective over here that the moment the graph touches stage 3, the survival at 5 years falls below 20%. So less than one patient out of 5 is going to be alive. This was what was projected in 2005 at the time where multimodality treatment was actually not the standard of care. And therefore, this led to what we know now as the treatment paradigm of CA stomach. We largely look at CA stomach separately for cardiac tumors versus non-cardiac tumors, and I am going to restrict the talk to non-cardiac tumors. There is a lot of overlap when we talk about this. The most important trials that come, that's FLOT, MAGIC, etc. There's a lot of overlap with lower end esophagus, G junction, cardia, non-cardia, but we will see what the numbers talk. If I have to put everything in one slide, this is the moral of the story. Gastric carcinoma, T2 and above, N positive, surgery alone is not enough. You want surgery and systemic therapy, which works better than surgery. Now, like I said, there are various ways we can factor this in. We can talk about adjuvant chemoradiotherapy. We can talk about flanking surgery with chemotherapy on either sides, that is perioperative therapy and adjuvant chemotherapy. We will discuss the evidence that has been laid down by these seminal studies and see what sense we can make out of it. So the aim of this talk is going to answer these 6 questions. Is surgery alone enough? Why do we need systemic therapy if we have done a good operation? How good is surgery plus adjuvant therapy? What is better, chemo plus surgery plus chemo or surgery plus chemo? Chemoradiation is required for which patient and in which setting, that is neoadjuvant or adjuvant, and surgery first can be done in which patient? So the first thing, surgery alone is not enough. So let's just remember the graph from the SEER database. At 5 years without multimodality treatment, the survival drops below 20%, and this is shown in these major trials. In 2001, McDonald's et al. Showed that with surgery alone, the survival was about 24% at 5 years, but with adjuvant chemoradiotherapy, it jumps to 40%. This is the Intergroup 0116 trial, which we will talk about again. The perioperative MAGIC study also showed the same, that with perioperative therapy, the survival jumps at 5 years to 36%, and the FLOT4 German trial, phase 2 and phase 3, gives the difference between the outcomes of ECF versus FLOT. So at least we need adjuvant therapy after doing a reasonable operation for carcinoma stomach. Again, I want to bring into perspective what the numbers are talking about. I already mentioned the results of the SWOG Intergroup 0116 trial. This was the trial which put adjuvant therapy into perspective. It just put adjuvant therapy on the map. And it said that chemoradiotherapy improves overall survival compared to surgery alone. Then came Magic, which spoke about 3 cycles of chemotherapy before and 3 cycles of chemotherapy after surgery, which improves survival. And we have a lot of data from the East, which says that S1 improves overall survival as well. The classic trial was actually looking at adjuvant therapy with Capox, capecitabine and oxaliplatin, and that also said that there is a difference in the survival curves that we see over here at 5 years, not just for overall survival, but also for disease-free survival. So, moral of the story, point number one, surgery alone is not enough. T2 and above and any node positive, it is prudent to give chemotherapy. Then the next question comes that initial surgery versus perioperative chemo, which is better? Now, perioperative chemo has certain advantages. We will talk about this alone, but if we have to just put it down to enumerate it, perioperative chemo improves survival. There is some element of downstaging of the disease. It addresses systemic disease and micrometastasis early on in the treatment paradigm. It has a role in evaluating disease biology and the sensitivity of the chemo agents which are being used. So basically, if the tumor is not responding, it gives us the chance of changing the therapy into a second-line therapy, either in the preoperative setting or after surgery, which the test of which is not possible if you've not given the patient chemotherapy in the pre-op. The fact of the matter is, which is a interpretation of the data from various trials, that about 60% of the patients following surgery are going to start adjuvant. So about 40% will actually not receive multimodality treatment. And therefore, there is a benefit of giving some amount of chemotherapy to begin with before operating. There is substantial data to suggest that distant failure occurs in about 2/3 patients. So we know that even if we do a good operation, good amount of patients are going to come back with recurrences, therefore justifying the systematic effect of the disease and chemotherapy before an operation. Let's look at the MAGIC trial. MAGIC trial actually changed the way gastric cancers were treated. This was a 2006 study which put into perspective the triple agent regimen, which is epirubicin, cisplatin, and 5-FU, 3 cycles before and 3 cycles after surgery, and looked at survival outcomes. So if we actually look at this patient characteristic table, although there was involvement, the patient population included stomach cancer patients, lower esophagus, and GE junction. About 74% patients on both the arms were CA stomach. So it showed that at 5 years that there was a substantial difference in the percentage alive, 36 versus 23 with chemo. Now the fact of the matter is that a good number of patients did not receive adjuvant therapy. But even despite completing adjuvant therapy or the total 6 cycles, there was a benefit in survival. The FLOT4 is the next trial, which has actually changed the entire paradigm of managing CA stomach. The phase 2, phase 3 trial was reported in Lancet 2019, which the primary outcome of which was overall survival. This is also a triple agent regimen, which requires 4 cycles of FLOT before surgery, given at 2-week interval each, followed by 4 cycles of FLOT, again at 2-week interval each after the surgery, versus the ECF 3 cycles on either side of the surgery. This showed that the overall survival actually was better for FLOT. So we are comparing 50 months versus 35 months with an improvement in the hazard ratio of death with FLOT. Not just that, the progression-free survival was also with FLOT. There have been some concerns about the toxicity of FLOT when it comes to ECF compared to ECF. Though grade 3 and grade 4 complications were seen both, but the incidence of symptomatic neutropenia, grade 3, grade 4 neutropenia was higher with FLOT, which is something that raises a concern. So the next question is perioperative therapy plus surgery. Is it better than surgery plus adjuvant? So although a lot of this data comes from the West, that is the previous trials that we have talked about, MAGIC and Classic, etc., This is data coming from the East. The East, Chinese, Koreans, Japanese, they are high proponents of doing a radical lymphadenectomy and therefore saying that they don't require preoperative therapy. But these two studies were large scale studies with a large sample size, which again went ahead to said that chemo, surgery, chemo, CSC, improved progression free survival versus surgery, chemo alone. So if I have to put it again, three hard points. Perioperative chemo plus surgery is better than surgery plus adjuvant therapy. FLOT is better than ECF. And in poor performing patients who will not be able to tolerate a taxane or epirubicin, dual agent can be preferred over triple agent, which is basically a good patient selection. Then the question comes, what is the role of radiation? Now, this is the SWOG intergroup 0116 trial by McDonald and al., which is, like I said, which was the first trial which put the concept of adjuvant therapy in CA stomach on paper. This is a widely quoted and widely cited trial which said that if the patients received chemo radiation in the adjuvant setting, because their observation was that about 70% patients will develop a local recurrence, there is a benefit in survival. And they did show that the 5-year survival, the median overall survival, the disease free, and the overall survival at 3 years were all better. But there are certain caveats to this. Although it did go ahead and say that there is better overall survival and recurrence free survival with adjuvant chemoradiotherapy, they set out to actually perform a D2 lymphadenectomy for all patients. But when they went back and checked their operative notes and operative specimens, they found that only 10% of patients had undergone a formal D2. So this first extensive data went to suggest adjuvant therapy helps, adjuvant chemoradiotherapy helps, but chemoradiotherapy has a significant role to play, especially when the lymphadenectomy is inadequate. Then the next question comes, adjuvant chemoradiotherapy is required in which patient? This is again extrapolated data from a lot of these studies, the SWOG intergroup 0116, CalGP, Artist-1, Artist-2 critics, and even the Dutch trial, that R1, R2 resection, inadequate lymphadenectomy, and even if a good lymphadenectomy has been done and the lymph nodal burden is high, there is some benefit of giving radiation to take care of the local recurrences. The next relevant question, of course, is can radiation be used in the preoperative setting? So the Top Gear trial actually went out to see if there was a benefit in giving radiation before operation. Given that there was a benefit of giving radiation after the operation, like the SWOG intergroup, but they found out that there was no improvement in overall survival, although it did increase the complete pathological response rate from 8% to 17%, but there was no translation of this benefit into overall survivals, but the complication rate was similar. But chemoradiotherapy in the preoperative setting cannot be just rejected and put into a dustbin. In locally advanced unresectable tumors to start with, there is some benefit of giving neoadjuvant chemoradiotherapy and then reassessing if we can actually take the person towards a resection. This is data which was recently presented at the ESMO 2024 and the ASCO 2024, which looks at the RENAISSA trial, which is a trial for stage 4 gastric cancer patients, which randomizes patients with oligometastatic disease after 4 cycles of FLOT to receive either surgery followed by 4 to 8 cycles or to continue with chemotherapy and put the patient out of an operative arm. This I would like to bring into perspective what Professor Sadaf said in the previous talk about the survival data for retroperitoneal lymph node resections when RP-LND is required in CA stomach. So they went ahead and defined limited metastatic status. I just want to point out that this is data, I haven't found the publication. This is data that I have extracted from the abstracts, which are available on the websites of ESMO and ASCO. So it says retroperitoneal lymph nodes, which is parapancreatic, retroduodenal, mesenteric, retroperitoneal lymph nodes, and or at the maximum one another organ with or without retroperitoneal lymph nodes. So it has to be either localized, potentially operable peritoneal disease, At the most, 5 lesions in the liver, which are potentially resectable, unilateral lung disease, which is resectable, uni or bilateral Krukenberg's tumors in the absence of peritoneal mets or disease elsewhere, and unilateral or bilateral adrenal mets. This is what they meant by limited metastatic status. And they showed that in the two arms, that is, to continue chemotherapy or to give surgery and then chemotherapy, in the overall cohort, there was no significant difference in the survival. So here it shows a log rank p-value of 0.8, suggesting that there is no difference. But when they did a subgroup analysis, the maximum benefit was actually found in the lymph node positive patients only. So only patients who have retroperitoneal lymph node positives, which actually can be seen in up to 30% patients with so-called localized CA stomachs, in which you will not find solid organ mets anywhere else. There is a survival advantage of first giving chemo, making sure that the disease is responding, doing surgery and an extensive lymphadenectomy, and then continuing chemo. So this one shows an improvement in OS of about 1 year. But the same thing was not actually reflected in patients with either liver metastasis or peritoneal metastasis. So patients who had extensive peritoneal metastasis and underwent surgery, actually the survival was detrimental. So it says 12 months versus 19 months. And there was no difference when the patients with liver metastasis were offered surgery. Actually, the complications in these two groups were also higher compared to the complications in the lymph node positive group only. This is my last slide, and I am just going to summarize what all we have said. So T3, T4, N plus patients, surgery alone is not enough. We have to give these patients chemotherapy after a good surgery. The tenets of a good surgery and an adequate lymphadenectomy have already been addressed by previous speakers. We address systemic disease with systemic therapy, and we want to do that early. So most patients should get chemotherapy before surgery in CA stomach. If for some reason preoperative therapy has not been given, adjuvant therapy is indicated after surgery. Chemotherapy alone if the lymphadenectomy has been adequate. Chemo surgery, chemo paradigm is much better than surgery followed by chemo paradigm. And FLOT has a survival advantage over ECF, even when adjuvant therapy is not completed. If in case of poor surgery, we must add adjuvant radiation. Poor surgery means R1, R2 resections, inadequate lymphadenectomy, and extensive lymph nodes positive even when adequate lymph nodes were removed. Clinico-radiological T2 node negative or patients who have a complicated disease that is presenting with a bleed or presenting with a perforation or gastric outlet obstruction, which is not allowing patient to receive chemotherapy. Surgery first is an option, but that better be undertaken with caution and not as a routine plan. Surgery in stage 4 gastric cancer patients has gained momentum. We have the data now, but it is super duper selective. Thank you.
Thank you very much, Dr. Deeksha.
Yes, sir.
Thank you very much for a very comprehensive, detailed, evidence-based talk, especially that's better, so that you have covered primarily the chemotherapy part, which was not included in any of the talks. Now, any of the panelists would like to ask any questions. It is open for discussion.
Excellent talk, Dr. Deeksha.
Thank you, sir.
Regarding the chemo, so you mentioned the FLOT as of now remains the first line in a fit patient. So what's your opinion on because still it doesn't become popular in the East. If you see the trials from the East,
Yes, sir.
they use SOX, the S1 with oxaliplatin, or the docetaxel with PEX. I mean, there are various other regimes, alternatives for FLOT, which are being explored. And now even S1 is available in India also.
Yes, sir.
So what do you think in a fit patient? So should we still giving FLOT, or can we try the other regimes also?
So I think in a fit patient, it makes more sense to me to begin with FLOT. In the adjuvant setting, one may end up changing to S1 for a lot of reasons, but which I have seen, which I have done, but I would rather begin with FLOT. Just I want to point out over here that if we look at the data coming from the West versus data coming from the East, there are very obvious biases which can be seen across various organs. Western people always want to give chemotherapy first. Eastern people always want to operate first. And there is a very huge bent on using S1 in Japan and in the Eastern countries. And obviously, so it's available to them. It's been working for them for a very long time. And of course, the sentiment that they are more aggressive surgeons than the Western surgeons. So there is this data which is biased in these directions. And we need to make most sense what suits Indian patients because they fit into neither groups, I feel. So just to draw a parallel, yeah, I would start with FLOT. But yes, in the post-operative setting, I may consider S1, but I would try and give FLOT as far as possible.
Thank you. Any other panelists would like to ask any question? Dr. Deeksha, could it be a reason that in the East, many of the tumors are more advanced and many of the tumors like South India, we have esophageal and gastric malignancy extremely common. So many of them come with obstructions. So how do you manage? Like it's very difficult to put stents or something and then give neoadjuvant chemotherapy. So what is your thought about that? Is that one of the reasons that it goes into adjuvant setting rather than neoadjuvant setting?
So that is there. It's not possible in India to ignore the socioeconomic aspect of a disease. In an ideal setting, if it were possible to keep the patient in an institutionalized follow-up, there is some value in putting in a nasojejunal tube, giving therapy first if the patient tolerates, and then operating. But it is a good proportion of patients in which it's not possible to do that. And therefore, these patients end up being offered a surgery first and then chemotherapy. But just want to bring a point over here that, like ma'am also said, there is a lot of value in trying to do a good D2 lymphadenectomy, even if we are operating for obstruction. That does have a difference in the survival outcomes for the patients.
Thank you. One last quick question. Okay, before I go, actually, I should ask that question to Dr. Anushri because she's a radiation oncologist, but because you covered chemoradiation, you said the first trial, 2001 trial, okay, that's a post hoc analysis which showed that it actually benefited in patients where less than D2 gastrectomy was done. And right now that has become one of the indications for post-operative this thing. In the adjuvant setting, you give radiation therapy. Otherwise, most of the trials are not finding any benefit of radiation therapy. So what is the consensus right now about radiation therapy in the adjuvant setting?
Yes, sir. So inadequate lymphadenectomy, less than 16 nodes harvested, not a proper D2 are
So let's say everything is done.
Yes. So
The
in that,
surgery is perfect. Then is there in role?
there is some data to suggest that a high lymph node positive burden has some benefit of receiving adjuvant radiation. That
But
data
in general, no, no, is it not? In general,
no. In general,
okay.
no. So
Fine. That's what I think we'll go to the next speaker because she's a radiation oncologist. Okay, it will not be fair to discuss too much. So now thank you very much. Excellently covered, Dr. Diksha, and